This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast. Hey, welcome back to the Alert Medic 1 podcast. Today you're going to have myself, Moose, and Aaron from PragMed. We're doing something a little different today. We're going to do a short episode about a case review and maybe roll in some topics from that case near the end. It's a new thing we're trying. Let us know what you think. You can DM us, comments, whatever. We're going to try this out. And today we're going to do a little case that I experienced, or that was from my practice. And we're going to be talking about a topic that has really gained a lot of oomph or power within social media and EMS in general. But we're going to be talking about CPR induced consciousness. So let's hit it. So a quick background on this. The agency that I work with is primarily an ALS chase system. We have a large amount of BLS units with ALS suppression pieces and chase cars. There are some medic transport units or ALS transport units in the county, but they are greatly outnumbered by the BLS units. Paramedics on every engine, along with some chase cars around the county, and we upgrade, downgrade as needed. So the way this whole incident starts, I wasn't even there. It starts as a chest pain call with an ambulance and an engine. They go and they find a approximately 50-year-old male complaining of chest pain. They found him laying on the couch, and he stated that he was taking a shower when he suddenly felt this chest pain 30 minutes prior. They get some information from him. He's got just previously diagnosed with hypertension 2 weeks ago, and he's been prescribed some atenolol. He's stating the pain is substernal and had some numbness in the left arm, but denies any jaw pain. They do what they're supposed to do. They do a great ALS assessment. He's ANO times 4. He's got a patent airway. He's speaking in complete sentences with no trouble breathing. His skin is dry, pale, and warm. Pulse is strong and fast. So nothing stands out on the initial assessment other than the patient states of some symptomatic chest pain. First set of vitals. His heart rate's 93. His blood pressure is 196 over 120. Respirations of 18. O2 saturation 99%. And they shoot a 12 lead. Can't see it here, but he has some elevation in V1 and V2, along with some depression in AVL 1, and then some slight elevation in AVR. So do you guys have any questions at this point? Just prescribed atenolol for that hypertension that was diagnosed 2 weeks prior. He is compliant. Okay. So they shoot the 12 lead. It qualifies under our criteria, and they decided to make him a STEMI alert, upgrade the call, and en route they get a second set of vitals. Heart rate's 89, blood pressure's 212 over 141, respirations of 18, and O2 saturation 99%. While en route, they transmit the 12 lead to the receiving facility. They're going to a CIC. They get an 18 gauge in the left AC. They gave 324 of aspirin, and they gave 0.4 of nitro sublingual 2 times. So as they're driving down the road, so the paramedic's in the back. He's got one other person. He's got the aide from the ambulance, and then the driver's up front driving. They're going priority one, lights and sirens down to the hospital. And at about 15 minutes into the transport, the patient says, "I feel like I'm going to pass out." And then he goes unconscious, becomes cyanotic from the mid chest up to the forehead. They check a pulse, and nothing is found. So this is where I come into play. So we just happen to be leaving the station to do some area familiarization, and we see them on the side of the road, and they're waving us down. As we pull up, we can see them performing CPR in the back. So I grab my monitor. We know they already have ALS equipment, so we get over there, find out what's going on. We, in our system, this would constitute 2 ALS providers being dispatched on the call. So luckily, we fulfill that second ALS role. So we get those 2 medics there on scene pretty quickly after pulses are lost and CPR has begun. So we get into this cardiac arrest. I get the story from the medic, tells everything I just told you guys. And CPR is being performed. We get pads on, we pause, and we find VFib. We get back on the chest, shock at 200, and then continue with high performance CPR. So in our jurisdiction, we at the time, and still, had adopted doing vector change for refractory VFib. So for those that don't know what vector change, take a look at the dual. But the dose VF trial from Canada. That's what really pushed this whole vector change thing. And we had decided, since we saw VFib on the first one, we're going to start preparing for a vector shock, because we do that after 3 refractory episodes of VFib. We did that with coinciding with the placement of the Lucas device, putting that on during breaks in CPR, not stopping CPR to put it on. We're doing this at our rhythm checks. Second rhythm, VFib, shock at 300. Third rhythm, VFib at 360. We gave 1 milligram of epi 2 times, 300 milligrams of amiodarone, and we started an LR bolus. So we've hit our third shock, and now we're considering moving to our vector change. Anything from you guys? Okay. So we hit our vector change ones. Now, something to, if you guys are doing vector change, communicate with your crew that you are switching pads, not this, haphazard, hey, did you do it? No, actually, make sure that the pads are switched between shock 3 and 4, so that you don't deliver a 4th traditional placement shock. Okay. So we're going to swap to those new pads that we're going to have 1 anterior, 1 posterior. The anterior pad is going to be what would be called your sternum pad. So the one that would be sitting on your patient's left side of the chest, that's going to go on the front. And then the one that's going to go up on the upper right chest is going to go on the back. This is how the electricity is delivered. It needs to be set up in this way. We send our 4th shock, 360 again. Between our 4th and 5th is when things get weird. So as we're still doing high performance CPR, the EMT that is bagging states to both of us, the both medics, that, hey, the patient is swatting at the mask. Okay, that's a little weird. Okay, let's keep on going. Let's see how this goes. Let's see if this persists. For about 10 or 15 seconds, the EMT continues to say, yeah, he's still doing it. He's still doing it. So I look at the other medics and say, hey, I think we should pause to assess if this is ROSC or CPRAC. This is definitely not something that's covered in protocol or really any hard guidelines on practice on how you do this. But I think this is one of those things where it's important for us to figure out, do we have a patient that we are now actively compressing their chest while they are awake, alert, and oriented, speaking, or do we have a case of induced consciousness? What do you guys think of that practice? Mm-hmm. I think at the time his end title was in the 20s or 30s. The rhythm on the screen was CPR, because we were at this point before I'm making this decision to halt or not. It's just a CPR rhythm. Um, so we have life packs. Unfortunately, we don't have the ability to have the see-through CPR technology that Zoll uses. So, yeah, 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 yeah. So that's what we did. And in that period where we paused compressions for about 15 seconds, roughly, he mumbles incoherently. He moves his arm vigorously at the BVM and then actually rips out his peripheral IV. And then within 15 seconds, he becomes flaccid. Check a pulse, no pulse. He's apneic. Okay, back on the chest. We had the Lucas on at this point, so we were using the Lucas for compressions. And that's at that point we decide that was CPRIC. So for those that, hopefully you've heard about this, but those that haven't, there is no really great definition of CPRIC right now. But the going interpretation of it is purposeful movement that happens during compressions and either ceases with cessation of compressions or within 10 to 15 seconds of cessation of compressions. Why the 10 to 15 seconds? 10 to 15 seconds because that's about how long it takes for that blood to stop flowing through the body and for that brain to be not perfused anymore. That's why we limit our pauses to less than 10 seconds, because there's this magic number of 10 seconds that's how long it takes to stop. So cessation within 10 to 15 seconds, we're going to be thinking CPRIC. Aaron, you had something? Okay. So we're going to say this is CPRIC. In my state, in Maryland, we are able to give ketamine at this point. This is one of our indications for ketamine. And so I then get the IO access because he has ripped out his line. We don't have access anymore, so we need to get IO. We did a humeral head. And that's what I prefer. That's what most people I work with prefer. I think it's great. We can talk about it afterwards, since that's been a debate a little bit the other day. And then we gave ketamine 1 milligram per kilogram for CPRIC. And so this is going to sedate them to a point where we're able to still do what we're supposed to do, possibly still get that airway established, but also do some neuroprotectiveness of the ketamine. We're going to use that to kind of calm them down so we don't have them thrashing about and making things worse. By the way, like I said, he went back into arrest. So our fifth shock and our fifth rhythm check is VFib, and we do another vector change shock at 360, and we converted him. We convert to a bradycardic wide rhythm. It was at a rate of about 40. We had not established an advanced airway by this point. Okay, so to give everyone a thought about this, so we're 5 shocks in. We are at least 10 minutes into our rest, and we have not intubated yet. You don't have to intubate in the beginning of your rest. Josh, say the intubation should probably be one of the last ALS interventions you do on a rest, unless it's a drowning. It's a high suspicion of a respiratory induced cardiac arrest, or it's a pediatric. Those are like kind of your big 3. I think that you really need to get that tube early than late. What do you guys think? Mm-hmm. Yeah. 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 True. Yeah. 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 And for those, if you're not currently doing it, a good idea to see your bag not compliance, your what's the word I'm looking for? Basically, if you're bagging well and you have a good seal, put an inline capnography device on your BVM. The numbers may be a little skewed, but your waveform, we're looking for waveform here. That's going to tell you if you have a good seal or not. If you're seeing good boxes, good seal. If you're seeing really just wavy waveform on it and not consistent boxes or peak and falls, that might indicate that you don't have a good seal on your BVM. So that's something you can kind of coach your BVM person through. So just an idea. So yeah, we rossed him into a bradycardic rhythm. It was wide QRS. In our agency, we try and do about a 10 or 15 minute, I don't want to say pause, but we have a post ROSC package that we want to do over the course of about 10 to 15 minutes. We don't want to rush it. This involves extrication or egress from the wherever we found the patient. This one was already in the back of an ambulance. Don't have to worry about egress. What do we do have to worry about? Possible 12 lead, but we don't do that because we're going to pace. We have a patient that's bradycardic in a wide rhythm. We're going to pace. So we already knew that he was a STEMI. Then we secure our advanced airway. We have the time. So we have the patient sedated with ketamine. We go ahead and pass that tube. It was a good tube. And then good ventilations via that tube the whole way to the hospital. Some things with the pacing, leads were popping off. So it was losing capture and also pausing our pacing when those leads would pop off. For those, remember, put your 4-lead on. You have to pace, especially. I don't know about Zoll or Phillips, but I know LifePak will not let you pace if you don't have a 4-lead on. And so we had some issues with that, but we constantly got capture back, both mechanical and electrical. But about 5-6 minutes out from the hospital, we lost capture completely. He rearrested, and he rearrested into PEA. So we restarted the Lucas. We were bagging. And then I believe we did at least 1 or 2 more EPIs. So, yeah. Any thoughts from you guys on the EMS care? Okay. I would say it's in our realm of dosing, at least in Maryland, it's a medium range dose. So your pain doses are going to be super small. Max of 20 milligrams you're giving. I think the 2 that I've done, the last one I did, I think I gave 12 milligrams. So like a super low number for a pain med that we're used to. Like we're used to, fentanyl, 1 mic per kg, and you're given over at least 50 on all your patients. And then your other end of the spectrum, your disassociation for your severe agitation patients, you're looking at high numbers, giving a max of 400. So this 1 mg per kg, I want to say this guy was, I think we shot him at like 100 kilograms. So he got 100 milligrams of ketamine, and we carry 2 vials, 1 high concentration and 1 low concentration for this purpose. So it makes it easier for calculations and not having a med error. Yeah. Yeah. No, correct. So that they're not trying to inhibit their own resuscitation. Yeah. and I'm sure there's going to be at least a handful of listeners that this is not a protocol you have. This is definitely starting to gain some traction around the U.S. And this was even, I remember when Maryland put it in, I was like, really? Wow, this is a thing, you know? So it's becoming more of a thing around. And that could be a whole nother talk, but I think anecdotally it's because we're getting a lot better at CPR. Just saying. Also, Mike would love to be here and hear this. Because we're using mechanical CPR devices, we are getting consistent compressions the entire arrest. Moose, anything? Yeah. Yeah. Yeah, I think we are. There was some. I want to. I don't think we ever had this as an indication for Versed, but there are places that had this, and Versed was the indication, or was the med given. And I think when we're looking at between the sedatives that we do carry, ketamine is going to be the safer option in these patients because we have a patient that is gone through the ultimate shock state of cardiac arrest. They are likely hypotensive in some way coming out of the arrest. They've got a weakened cardiovascular system because of what's happened. Likely a cardiovascular event is what caused it. And we don't want to drop that blood pressure with Versed and or another type of benzodiazepine or something that has a greater vasodilatory effect than ketamine. Yes, and you can. Mm-hmm. And so does emergency resilience. Mm-hmm. Yeah. Uh, I would say ketamine is our best option right now, outside of doing some kind of RSI type cocktail. Um, it is a great uh, sedative that has um, yeah, pain control, but also we don't have the vasoactive components of it as bad. Yes, can it drop blood pressure? Yes, because it raise blood pressure. Yes, but no profound on either end of that. Um, well, that's the other thing is that they are finding that it has neuroprotective capabilities. Um, so it actually does help preserve some of that brain function after someone's been in this hypoxic state. Luckily, with this patient, they did walk out of the hospital. Yeah, they were in the hospital for 2 weeks. They went home. They got a cath. The patient, he tried to extubate himself in the ER. The guy received CPR for almost an hour, but it was consistent CPR. It was good compressions, proper depth, proper rate, both manual and by Lucas, and it kept that brain perfused. And I'd like to believe that the ketamine helped in that brain perfusion and brain protection. Um, and I don't have any studies in front of me, but I do know there is a lot of talk about being neuroprotective. Um, I think this is anecdotal for me at least. The people I've heard that talked about seeing it, it's always been in a VFib VTAC. A lot of witness arrests, um, and there is almost always and then associated ROSC involved as well. Positive neuro outcomes, mixed bag, but it's almost like your fresh arrest in a VFib VTAC when the heart is most vulnerable for this, and then throw in things like high performance CPR, pit crew mechanic or pit crew systems, and Lucas devices or auto pulses, and like where it's all about perfusing the brain. And if you have a viable heart, which we all say the most viable is the VTAC and VFib patient, then yeah, I mean, Moose, you got something, anything? And there isn't. uh, I don't know. That's news to me. Um, Yeah, I think we're going to here in the near future because it is becoming a thing. Before it was like it truly was like one offs, and the study you just sent about that they studied the UK paramedics, most of them didn't know what was going on until it happened because they didn't have the education. And I know, like, yeah, yeah, yeah. And I would wholeheartedly agree with that. I mean, this this positive outcome of this whole call is because of the basics of CPR: good compressions and early appropriate defibrillation. Everything else outside of that was just gravy. It was extra stuff. But without those, no, we did not. um, but it's all about those basics. And something I said, I think I commented on emergency resilience post about it once, or it was a post about CPRIC, and someone was scared when they saw it happen, and that how they felt about it later, and that it was off-putting. And what I want to say to our audience is, if you do see this, this is a sign that you're doing things right. Don't be scared of this. If you have the protocols to treat it, do so, but don't be scared of it. Don't think you're doing something wrong. This is you doing the right things, because they can't have this happen if they don't have perfusion to the brain. And even if it is in the end a ROSC, once again, that's a win for you. That is you doing the right thing because you did the compressions correctly. If you defibrillated early and appropriately, and then you did everything else swimmingly as well. So this is all good things. This is not you inducing harm to the patient. This is not something that should be looked at as faux pas. This is good. Sure. Hmm. Oh, a waking the dead moment. It definitely sounds like it could have been. And I would say it would be even rarer in that instance because it's a traumatic arrest. But I mean, let's be honest, dead people don't just raise up. That's understandable. I mean, Somewhat, but Lazarus is actually usually like nothing's been done for like 10 or 15 minutes. Like you call the code and like 15 minutes later they get a pulse back with yeah. Yeah. Okay. Well, that basically concludes it for the case. I'm not going to go into the whole hospital care. Like I said, this guy did walk out of the hospital um, and is living a healthy life now. He's still alive. Um, so, yeah. Okay.